Hello, Mac. Here we go again.
Hey Pam, how are you today? You're looking good.
Thank you. I'm feeling good. I just celebrated a birthday and was back to work this week. It's always crazy getting back to work, but it felt really good. I miss what I do, but I love having fun too. You know that we play hard and we work hard.
That's right. So 2 weeks ago, I had a birthday too. I may be a little older than you two.
Oh, just maybe
I'm
back a couple
28.
years.
Well, yeah, just a few years.
Well, happy belated. I didn't know that. We'll have to celebrate together next time we
There
see.
you go. There you go. Looking forward to it.
So let's kick it off today. We are going to close the trifecta of pain, right?
Right.
TMJ pain.
So, trifecta, for those who have not listened to our other podcasts, there are three different occlusal schemes. Occlusal is the way the teeth come together. And there's three different ones that dentists like Pam and I look for. And that is posterior interferences, which we're going to talk about today. We've already talked about the torch mandible, which is one side hitting before the other. We've also talked about a deficient maxilla, and Pam went into great detail about how kids who don't develop correctly have a deficient maxilla, which is the upper jaw. So, but today is the one that's a little bit more complicated to understand and wrap your head around, and that's posterior interferences. I learned about posterior interferences in 1977, 5 years after I graduated from dental school. And it was a complete eye opener to me of the real world of dentistry that we did not learn in dental school. I don't know about what you learned, Pam, but I didn't learn anything.
Mhm.
And so, simply said, posterior interferences are where the back teeth are in the way of hitting in harmony. And it creates problems like gears in the car not fitting. So, what I need to know from you, Pam, because we've never talked about this, is what was your education in posterior interferences or the way the teeth hit? And did you learn any of it in dental school?
Mac, we learned maybe 1% of it in dental school. Sadly, there's something that we are taught called occlusion, and that's how the teeth fit together. All dental schools teach that, but literally, it's more about they teach us, on a mounted articulator where we take like stone models of teeth and mount them on top of each other and then make fake chewing patterns like sliding them side to side and then you put wax on them, but we had no idea how how jaw movement, how that masticatory function impacts the way the muscles work, that impacts the feedback to the brain and the whole pain pathway. So we weren't taught any of that. That's stuff that we had to learn going back, like after school, like learn more about, right? So
Yeah.
mine was 20
It-
years
it-
ago, and not a whole lot's changed from what I see in the dental schools still.
so here's another thing. Those stone models and those plastic models that we worked on,
Mm.
they weren't connected to a person. They weren't connected to the periodontal ligament that tells all.
Right?
So we were just going into it blindly.
Yeah.
Okay, so what is a posterior interference? Is try to make it as simple as possible. And for those not watching the video, I'd like for everybody to kind of relax, slightly close down, and slide their teeth forward till only the front teeth hit.
Mhm.
When you do that, you'll notice that your back teeth come apart. And that's the way that it should be because the posterior teeth, the back teeth, are not touching. And if they're not touching, they don't have interferences. It's as simple as that. An interference is just an interference of physically how the tooth is being contacted. Now, here's the tricky thing to do. Instead of going forward, slide to the side. Slide to the side. It's very hard for people to do. And if you're sliding to the side and you feel back teeth hitting, that is a posterior interference. So, and Pam, in your education, where did you have to go to learn that? And why aren't other dentists knowing this? This is really needs to be known by all dentists.
So what a lot of patients don't know is that there are different occlusal philosophies, believe it or not, meaning philosophies on how to put a person's teeth together so that it's balanced. And depending on where you choose to get your training, you're going to be taught on different philosophies. Most of my training after dental school was done on the West Coast, and it is a neuromuscular philosophy, meaning, our training, it was many years and a fortune. And sometimes we even have to take patients there and work on things live. So, and it's a continued learning process, right, Mac? We always have to continue to sharpen our saw.
Always.
Our background, yours and mine, in neuromuscular is that if we can get the muscles to be in a balanced position, then the feedback to the brain is calm and relaxed. And then you put the teeth into that balanced position. So our philosophy is that if the teeth are in the right place where the muscles are balanced and working physiologically correctly, then everything is calm, everything feels harmonious. But then there's other philosophies that I think you started your training out in Pankey. Is that right?
Yes. 1977, yes. And then went to Dawson and then went to Coyce, and all of them had basically the same philosophy. So
Mhm.
you mentioned neuromuscular, and let the public know that the different dental camps think they're the only ones that are right.
Mhm.
And we have to stop that. We have to find out what our similarities are with these different camps. But let me give you an example of neuromuscular that has nothing to do with teeth. If you get a grain of sand in your eye, what's going to happen? The body's going to respond. It's
Mhm.
going to tear up. You're going to want to scratch it. You're going to want to itch it. You want to flush it out, and the tears continue until it's flushed out. So you've gotten rid of the obstruction in your eye. That's all a neuromuscular event. If
Mhm.
you have an obstruction in the way that your teeth come together and fitting in harmony, like you said, harmony with the muscles and with the joint, that is a discrepancy that is going to cause a neuromuscular event and or is going to cause destruction of the teeth. When the gears don't fit right in a car, they're going to be destroyed. When the teeth don't fit right, they're either going to be destroyed and are going to cause pain.
So tell me what you think about this analogy, because I want our listeners to really kind of follow this well. Um, I imagine like if you had a pebble in a shoe, okay, like you had a really small rock in your shoe, and you can walk and walk and walk and not even know that that rock is there, and your body, your movement might actually be compensating to avoid that small friction, to avoid pain, right? Well, you may not know it's there until you walk miles and miles and miles and miles, and then you feel pain and soreness, not just at that location where the pebble is it, but in the rest of your body for that compensatory movement. And also that constant feedback loop to the brain is causing a lot of like, it can cause frustration and short-temperedness, anxiety, because your body's been constantly trying to digest something below the radar that it's been dealing with. Well, posterior interference can be exactly just that with back teeth. It can occur because of the way the teeth came in, like if the teeth came in crooked, it can happen because of dental work. How often have our listeners maybe have had a crown or a filling done, and you feel like when you put your teeth together, something's not just quite right, but you can't put your finger on it, unless it's really off, but you just, something's wrong. And then over time, the tooth gets sore, hypersensitive or oversensitive to beverages or just tender to the touch. That is also a posterior interference. And these are things that Mac, you posted images of this, I think are fantastic. And patient or listeners, you might understand this, like when the dentist puts that paper in your mouth and they're like,
Tap, tap, tap.
tap, 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 right? And then they're looking at these blue and red squiggly marks, trying to see if they've got the bite right. That's what they're checking for. They're trying to see if it's level and if there's a weird interference when you move your jaw forward and back or side to side, trying to mimic what you do when you're actually chewing. But half the time that's not right, because most of them are not even trying to sit the patient upright, because when we eat and when we're functioning, we're upright. We're not laying down. I mean, I haven't had a gentleman feed me laying down before. I haven't trained anybody to do that for me, Mac. I still sit and eat my food on my own. So the bite needs to be checked in an upright position, because our body posture also affects that, and then we can be missing posterior interference. How is that for an analogy?
Yes, and what is so fascinating about the human body, and especially with teeth, is a thing called the PDL, the periodontal ligament.
Mm,
And that is tiny sensors that surround every root of every tooth. And these sensors are directly connected to the brain. They don't have to go through the spinal cord. So they are also mechanical receptors, which mean they have the ability to tell the jaw where to move.
mhm,
So if, like in your car, if your tire is starting getting out of air, your light sensor comes on. So when you have dental work done, if it doesn't feel right, your sensor is going off, but you're trying to explain it to a dentist that doesn't understand occlusion. It's a bad situation because you know it doesn't feel good, and the dentist keeps saying, no, it looks right, it looks right. Well, they
mhm,
don't know how to look for the red and blue. They don't know how to look for
right.
posterior appearances. And it's an absolute necessity that they learn how to do this.
And that's such a good point. It's like a lot of dentists don't know how to interpret what they're looking at.
Right.
And if they're, aside from that, if they're keeping the patient laying back, we don't eat in that position. Like listeners, like if you are not driving and you can, I mean, just close your eyes for a moment and put your teeth together and, just very lightly tap your teeth up and down. Okay, now stop. And then, lay your head back or tilt it all the way up to the ceiling, chin up to the ceiling, and really slowly open and close. Tap your teeth there, and you can feel that it's different. You're probably touching the back teeth first, or even if you bring your head forward and you tap your teeth there. The point is that our body posture also affects our bite. So we have to keep that in consideration. And then something, Mac, I use and you used to use in your practice is called the T-scan. You talked about it last time a bit when we're talking about horses and horses getting better treatment than humans do sometimes.
They're very expensive.
Yeah, right. But that T scan is an extremely accurate. It's like instead of using the blue and red paper that dentists do, we use and it's a computerized, very thin bite wafer that goes over all the teeth, and you bite into that, and it records by milliseconds the exact amount of pressure that's occurring and where. And that's beyond important when you're trying to work with patients that suffer from TMD, or you're doing tons of crown work and rehabilitating somebody's bite or making an orthotic appliance, right?
Right. And so the blue and red mark take care of the same principles of good occlusion. And a good occlusion being the bite, when you bite straight down, all the forces on the back teeth should be down the long axis of the teeth. It only makes sense.
Mhm.
So when you pile drive a log, you want it to be straight. You want to hammer a nail, you want it to be straight. When you bite down your teeth, you want to be straight down the tooth. So when you go from side to side and the back teeth are hitting teeth, they're knocking them to the side.
Mhm.
And that over time is going to create all kinds of problems, either destruction of the tooth, the bone, and or TMD pain. And
Yeah.
the PDLs are going to pick up any movement or any incorrect hitting up, I mean, around 30 microns. 30 microns is a dust mute. It's nothing. So when you have a dentist like you and I that are experienced in making these orthotics fit, we're looking for discrepancies of less than 30 microns. And
Right.
it is a real art. And you really have to know what you're doing to be able to get an orthotic to be and take the jaw and the teeth in a harmonious position.
So let's tell our listeners, like, how to help themselves look for signs and symptoms, kind of self-diagnose. I say that very loosely, right? Because we're always trying to help you guys kind of see if this is something you're suffering from and what to look for. So when Mac's talking about like dental destruction, well, obviously, like if a tooth breaks, that's dental destruction. But sometimes it can be more subtle. Like when you see wear, meaning like where teeth used to be pointed, but they're flat on back molars, or even in the front teeth where they're chipping, that's dental wear. That's not a getting older thing. I will see 80-year-olds with no dental wear. It's not an
Right.
age thing. It is either grinding, what we call parafunction, or trauma, if you bumped your tooth or something. The other thing you just alluded to is called abfraction, AB fraction. There's a difference between aggressive toothbrushing, okay, which will cause notches at the gum line, like little notches on the teeth and gum recession where the gum pulls down. If you're an aggressive brusher, like a heavy-handed toothbrusher, you'll see troughs going, on all of your back teeth because of that constant friction going back. Again, we're doing gestures. If anybody wants to see what we're doing, this is also on our YouTube, but hopefully we're explaining this well so you can conceptualize it. But the difference between a grinding issue and toothbrush abrasion is you don't see it in all four quadrants in the back. You'll see a very site-specific notch, like someone took a tiny little axe and picked at your tooth right at the gum line and makes this triangular notch that eats away at the tooth and pulls the gum down. That's abfraction. And Mac was just talking about each tooth ideally should have force going down a straight on vertical vector, right? Not at an angle, like a hammering a nail. So what happens with teeth, if a tooth is kind of tipped in, every time you compress when you're eating food on it, the tooth will bend in, and right at the neck of the tooth, right where the tooth meets the gum line, it will cause microflexion, and then you'll start having bits of the tooth structure start to like flake off little by little. You won't taste it, you won't feel it. It's really that kind of micro erosion there. But over the years, you'll see the notching occur there. That is a strictly an occlusal issue. That is an indication that you are clenching and grinding. You have a posterior interference that we're talking about, and it needs attention. Does that make sense?
And my analogy on abfractions is if you have a post and cement in your garage and every day you back out with your car and you hit that post, over time it's going to break down at the ground level the same way that the teeth are going to. Now, if that post was in sand, it would move, and that's recession. So recession and abfractions, we're getting into some pretty detailed stuff. But this is how important the bite is. So, but your dentist, when you're being diagnosed, your dentist needs to look for abfractions. They need to look for a recession. They need to look for anterior wear. So
Mhm.
if you look in a mirror and you see that your lower teeth are worn and you've got a yellow spot in the middle,
Yeah.
that means you've worn your teeth down to the dentin. Now, why is that important? Well, a lower tooth is like 11 millimeters in length and it's covered by 1.5 millimeters of enamel. If you worn down to the dentin, you have destroyed over 20% of your tooth.
That's a lot.
It's important. That's a lot.
Yeah,
If
that's a
you had,
chronic condition that you just don't know it's
yes.
going on. TMD doesn't always have the headaches and the ear issues and all the pain issues. It could be very silent, like blood pressure, right? Until something might trigger you, a broken tooth, or you might yawn real big and then your jaw gets locked. It can manifest in so many different ways.
In one of our podcasts, we will need to talk more about the joint because there's so much confusion on the social media Facebook pages about the joint. If I have a clicking joint, what does that mean? Do I need to get help? Do I need to do this? And there's so many variables. There's so many variables. There are more variables in TMD than stars in the skies. And so again, your dentist has to
Like,
have the time and has to have the want to sit down and hear your story because everything fits the whole. That's the thing about neuromuscular dentistry. We look at the whole body. We look at all of the things that can create the problems that TMD sufferers are having.
yeah, and I think let's wrap up with that. It's a really good point, Mac. I would like to really believe that, dentists, people who become dentists are nurture caretaker type people. They genuinely want to help people. We do
They
swear an
do.
oath to that. I want people to understand that if your dentist doesn't look at these things, it might be because she or he just doesn't know. They didn't
That's
have
right.
that training. And if they put in a crown or a filling that's off, you do need to like advocate for yourself and go back to them and have them look at the bite in different position. And yes, it can be very frustrating, but just keep in mind, people don't know what they don't know. That's why we're here doing this podcast. We're trying to open up. I'm
Right.
glad that we're not just having regular people listen, but we're getting people are reaching out to us that are dental students and different doctors So, fingers crossed, we're creating the awareness and making our dream come alive, Mac.
There you go. Very good. Very
All
good.
right, so we'll talk more about the joint and also what about that trigeminal nerve,
Oh,
trigeminal neuralgia, right?
that's a big one.
All right, hope
Okay.
we didn't overcomplicate this too much. See you next time, Mac.
Next time. All right.
Bye.